Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear viewers, ladies and gentlemen. Hello and welcome after summer break. Once again, Dr. Muhammad Al-Sheef, your host of Elixir of Life, is kicking off another inspiring and informative episode with our distinguished guest to explore and highlight new frontiers about male sexual dysfunction. Stay tuned for a special episode. Once again, welcome to Elixir of Life. We'll start our program with the first segment, Quote of the Week. To watch for more details about this quote, stay with us. Once again, welcome back to Elixir of Life. Now we are coming to our episode's theme. Our topic today is very common and significant medical problem, yet it is very sensitive. We will be talking about sexual dysfunction among men. To explore more about this topic, the incidence, prevalence, causes, diagnosis, treatment, and state-of-art advances, it's my immense pleasure and honor to present my distinguished and esteemed guest, Dr. Maher AlMoazen. He's a consultant urologist with subspecialty in male sexual disorder. Welcome, Dr. Maher.
Thank you very much. Appreciate it.
It's really a very important topic, and we'll start to talk about what are the male sexual dysfunction disorders.
Bismillah ar-Rahman ar-Rahim. The commonest male sexual disorder, there are many, but the commonest are erectile dysfunction, what we call it impotence, or commonly called impotence. And the other one is ejaculation disorder. That include anejaculation, erectile or retrograde ejaculations. There are the commonly seen disorder of men. For erectile dysfunction, it's the commonest among the rest, and the commonest reason to visit or to see physician or consultant specialist in the field is erectile dysfunction. It's a worldwide problem.
So, excellent. So it is, male sexual dysfunction doesn't mean only erectile dysfunction. It encompasses other, as you mentioned, ejaculation disorder and hypogonadism, etc. So to highlight this, erectile dysfunction, Dr. Maher, do you have some, figures about the incidence, prevalence, locally and internationally?
Yes. Let's highlight with the definition, international acceptable definition. The sexual dysfunction or erectile dysfunction means inability to sustain or maintain erection adequate enough to be able to be involved in the sexual intercourse in more than 50% of the time. And this is commonly seen in men, and the reason of late consultation, because men, they shy away from this from the first episode. Either if they're newly married, they get so stressed and they go on vicious psychological cycle that make it worse and worse, or they are very well married, but it's gradual offense, so they don't appreciate it, but they try to avoid it in order not to be involved in embarrassment situation. it has a major impact on the patient and on the self-esteem, on the interpersonal relation with the partner, as well as the quality of life. And also, it is a major signal, or very important signal, that might be potential underlying cardiovascular disease. The physician should pay attention, or the patient himself should pay attention to it and seek a consultation.
Excellent.
The commonly the studies quoted prevalence worldwide, currently 152 million worldwide suffering from erectile dysfunction, and the expectation it reach up to 322 million worldwide by 2025. Commonly seen, the youngest quoted in the literature age is around age of 18, but commonly seen between the age 40 and 70-year-old men. There is it's very important to know the physiological underlying background.
So doctor, this is internationally. Do you have any local data about incidence and prevalence of erectile dysfunction in Saudi Arabia?
Is not very broad, but it's the largest quoted number in the Annals Journal in 2000, Saudi Annal Journals in 2011. It was mainly related to diabetes. And it shows that 30% of our population are diabetic, and men and women are equal, roughly. And in men who are diabetic, particularly type 2 diabetes, the 11% of them, they are suffering from mild type, and up to 80% they are suffering from moderate to severe type. And other quoted data, this is Journal of Family Medicine and European Review of Journals, shows again same number, and also show there is a relation also with what we call it hypogonadism. That means testosterone level is low in those group of patients, and the same number whoever having diabetes, low testosterone level, 87% of them, they are suffering from erectile dysfunction.
Excellent, Dr. Maher. So it's a genuine medical problem, is not myth.
Is not.
It's a fact. Huh?
It is a fact. I like the question because the people that are going that far in this question, they feel is not existing, or because they are trying to deny it, and they're running away from going further for investigation, particularly involvement of another partner. And it's so embarrassing to unable to penetrate the part.
Excellent. So to highlight this topic, could you explain the anatomy and physiology or physiological basis of erection?
Okay.
And the
if you don't mind, let me go on the slide. So, as the slide here shows, this is the normal erectile function, the organ, what we call penis, and all the three parts from outside. But particularly, you need to highlight on the left side slide where it shows the sponge part, the upper two part here. The two sponge part, they are the sexual responsibility for sexual erection, and this is a sponge-like, and when the erection happen, in simple way, it get filled with blood, and this get congested and engorged, but there is a surrounding whitish layer there around it, what we call it tunica albuginea, and that part is responsible to keep the pressure high inside and the blood. So by this, it gives you the rigidity of the erection, and also they prevent the venous backflow by compressing on the vein during the erection phase. So this gives you full rigid erection and to be able to penetrate the partner. Can I get the next slide, please?
So that's okay.
Yeah.
At the cellular level.
So this is going down, zooming in more at the cellular level, and taking a piece of the cut on the cavernosal tissue that on the left side on the previous slide. This is made of three components. This is the cavernous tissue. The smooth muscle is made mainly from smooth muscle, and this is the neurological element, and this is a vascular element. Particularly this element, the neuro and with the vascular element, in summary, give something very critical element, what we call it nitric oxide. This will stimulate inside the tissue the certain element cyclic GMP formation from GMP, and this cyclic GMP will go inside the cell and will move the calcium away to the endoplasmic reticulum to retain it there. And this this will lead to relaxation. Actin will come off mucin and will lead to relaxation of the smooth muscle, let more blood come to the tissue and get the erection. So after the erection and ejaculation, sympathetic outflow of nerve stimulation goes to this, and this will lead to more calcium coming back. Calcium bind to calmodulin between the actin and mucin and lead to two of them slide and lead to contraction. Less blood flow will go, and the erection goes down detumescence phase gradually, and the detumescence phase happens.
Excellent, doctor. So this leading us to the next question: what are the classification,
yes,
major classification of erectile dysfunction?
Yeah.
Okay.
Can I see next slide first? Yeah. So this is more highlighting to the more critical element, and increasing of this inside the neuro level will decrease the calcium and lead to relaxation and erection. Stimulation by a sympathetic phase will lead to increase in the calcium inside the tissue, as we mentioned, and contraction. Next slide, please. These are the phases. As we start the flaccid normal phase, and then with any audio-visual stimulation or tactile stimulation, latent phase and penile filling and lengthening happen by more flow of blood coming up. Tumescence phase, rising intracavernosal pressure at this phase, more blood coming. Full erection, increase the cavernosal pressure to the max, and it might reach to equilibrium at this level. Rigidity will increase it further by stimulation the pelvic muscle to contract and give it more rigid phase. It will be adequate for penetration. After ejaculation happen, sympathetic flow happen, and then will lead to detumescence phase. So the common cause, next slide please. The common cause, we classify it into two phases: psychological underlying cause and organic. Organic could be from vasculogenic at the level, could be arterial, could be venous, could be mixed, and could be also from the tissue itself, or could be neurogenic. Neurogenic could be at the higher level and at the brain level. It could be any underlying cause: multiple sclerosis, Alzheimer, stroke, and going down to the spinal cord injury, and commonly we see it in the trauma patient, and going down all the way to the peripheral nerve, that where diabetic neuropathy lead to inability to achieve erection. Endocrinology cause, again, could be multiple: hypogonadism due to testosterone level decrease, adenoma of pituitary gland will compress on the surrounding structure, minimize the production of the stimulating hormone, and also diabetes by itself, for multiple reasons, can also lead to this. The commonest underlying causes is psychological, and could be generalized or situational related. Could be partner related, could be performance inability to do, could be stress. A lot of factors need to be addressed when you counsel your patient. Knowing detailed history is very important to highlight and put your hand on the potential underlying cause.
Excellent, Dr. Maher. That's very important. You enlightened us about the causes. Yeah. So just to, if you sit down, okay, to talk more about the relationship between diabetes and erectile dysfunction, because you mentioned that one of the causes,
yes,
cause peripheral neuropathy, damage to the peripheral nerves. Okay.
Yes. Mm-hmm. Yes. Well, the potential underlying cause, it's well-known association between Peyronie's disease and diabetes and venous leak, diabetes and peripheral neuropathy. But the exact at the cellular level, what's happened, diabetes itself will damage the nerve that produce the nitric oxide that I mentioned earlier. And so will minimize the nitric oxide production. Also, diabetes will damage the endothelial layer of the receptors in the endothelium at the vascular level. free radicals will be high. That will stress the tissue and cause more damage. So that, in addition to the vascularity, lead to atherosclerosis, so less blood will go to the tissue in comparison to before the diabetes, alarming due to hyperlipidemia association. So putting all this together, that's why diabetes cause a major impact on the patient with the or generate erectile dysfunction, and that will lead us to the guideline of the first thing need to investigate when the patient presents to you with the history of inability to achieve erection. That include what we call it American Urology Association guideline. Now you have to really to investigate for fasting blood sugar as well hemoglobin A1C to ensure that patient blood sugar is very well controlled, to check fasting lipid profile to ensure that the patient is not having hyperlipidemia. And studies shows that this might be the first sign of leading or guiding the patient, guiding the physician to diagnose a potential underlying cause of vascular disease.
Excellent.
And it's been quoted a lot of patients that they have narrowing of coronaries lead to further treatment on that side before they consider the erectile dysfunction.
So I understand what you have mentioned, that impotence, erectile dysfunction is very important symptom and sign of cardiovascular disease.
Absolutely.
Could be the earliest symptom.
Absolutely.
So once the patient present with erectile dysfunction, you should investigate for diabetes and other cardiovascular diseases.
Absolutely. Absolutely.
So that's really important because, as you mentioned, because they affect the microvascular level.
At the microvascular level, absolutely.
Okay.
Cellular level as well. Yeah.
Anyway, like we will talk more about smoking and other, and now we will move to the next common male sexual dysfunction disorder, which is hypogonadism.
Yes.
Can you enlighten us more about this?
It's really very important and question, and the reason making it important because it's very common. And the awareness of it by the general population as well as physician, believe it or not, the awareness is not that much. The patient, because the symptoms and the presentation, they don't come just by with the erectile dysfunction. It's general, and the level of testosterone, the hypogonadism in summary, is level of testosterone go down below what it should be. And there is multiple reasons for this, but aging is one of them. The other reason also diabetes association with this, obesity underlying cause, because testosterone will in the fat tissue will convert it to estradiol, so it does not function on the receptors of erection as it used to be. And this is why we're saying obesity is not good for the health as well as for erection. It is a fact, it's not a myth. So the level of testosterone, when it goes down, in addition to the symptoms, there is generalized symptom and there is local masculine effect. The generalized symptom at the level of the brain, the mood disturb, and the patient memory will affect it, and the patient feel generalized fatigability, and the hot flashes as well. It's like andropause. Menopause, we call it andropause here.
Okay.
In general, also for masculinity, the muscle bulkiness will be reduced. Osteoporosis, they are more prone to osteoporosis on this phase. Gynecomastia, enlargement of the breast in men. All these, in addition, also erectile dysfunction, infertilities, desire, decreased libido, what we call desire of having sex will be reduced. They don't want it anymore. So all these, putting all these signs and or symptom or concern together will raise alarm that you should investigate your patient.
Excellent. So it is a multisystemic disease rather than, just affecting the erection. Okay.
Absolutely.
Erection plus other, like osteoporosis you mentioned, and obesity. You brought very important point. Difference between libido and erection. What's the, because people, they might, confuse
Libido is the desire, but does not mean you might have the desire, or the person might have the desire but unable to perform.
to maintain
or to be able to achieve erection. So this is very critical to know this, and because there are certain medicine can cause that, commonly seen at the elderly when the prostate get enlarged, they take certain medicine, 5-alpha reductase inhibitor. This by itself, it has an impact on the erectile. In addition, especially particularly if the patient is sitting on the fence, on the borderline kind of erection ability, the desire will go down. So they don't feel they want it anymore. The audiovisual stimulation or tactile is not stimulating them as it used to be at the younger age. So it's commonly happen in elderly, in diabetic patient, or obese patient. You see this. So the alarming, please, if you any of these concern for a patient as well as a family physician, if you feel your patient is having these symptoms or a bunch of them, please feel free to investigate for testosterone fast early morning testosterone level. That include testosterone, bioavailable testosterone, and free testosterone. These to ensure that the patient at that early morning at 8.
Why early morning, doctor?
Because the peak of testosterone happens. Physiology. Peak of testosterone will shoot up in the morning, just before noonish time, and they start decline after that. So that's why in the early morning, you need at 8 a.m. you need to investigate for testosterone level.
That's why we have the normal erection, and the physiological, in the early morning. Because of the coinciding with the peak of...
that's one of the underlying physiological cause. But at night, what happened, the eye, the sleeping phase, what we call REM, this phase is the...
Rapid eye movement.
Absolute rapid eye movement. The flow to the penis will increase at this phase. It does not reach to the full erection, but it will increase. And that's why one of the commonest questions to differentiate between organic and psychological is to ask, do you have erection at night? If they do have them, most likely you are dealing with psychogenic underlying cause. Yes.
Excellent. That's very important. So just to close this topic about the hormone replacement therapy. We'll discuss it more in the treatment. We move to the third, and less common male sexual dysfunction, the Peyronie disease.
Well, again, this is not, as you just mentioned, is not very common, but or what I call it, not uncommon. It's there, but the people they don't come to counsel you until it's really interfering with their sexual relation. The Peyronie's disease basically is a benign pathology or disease happen as a defect in the what's happened during the erection phase. Penis go into curvature, either dorsal or ventral, and this is what's happening because there is a fibrosis or fibrous scar tissue within the cavernosa or albuginea. And there is a lot of theories, I'm going to highlight on them, but this is basically what's Peyronie's disease. So when they have erection, it gives a curvature. It's not straight anymore. It can be cumbersome to the extent that it interferes with their sexual ability. It can be severe, more than 60 degrees. And it can give pain to the partner as well as the patient during the intercourse. It passes through 2 phases. Phase 1, the active phase. This is usually the first 6 months. And then from 9 to 12, the quiescent phase. The active phase usually is the inflammatory process phase, and it's painful. And this phase, is you don't do any surgical intervention. Mainly you give oral and support. And the quiescent phase, when it's very well established, then you might consider surgery.
Okay, great, good. So this is Peyronie disease, okay? And what about ejaculatory, dysfunction, like premature or ejaculation?
Premature ejaculation, that the patient within a minute from penetration or just before penetration, they go and they give ejaculation unwanted, and is distressing to the patient as well as the partner. They did not reach to the orgasm, both of them, and that give disappointment to both. And again, it lead to avoiding the sex again in order not to overcome the similar situation.
Excellent. So 1 minute is the cut off point, okay?
Yes, 1 minute. And this is what we call it the premature ejaculation. There is something called retrograde ejaculation. Retrograde ejaculation, that where they ejaculate, they feel dry ejaculation. They have the feeling of orgasm, but there is nothing coming out. Commonly we see what's happened during ejaculation, the bladder neck close. So the flow of ejaculate go in one direction to the partner vagina. But in this phase, in this stage, what's happened, the bladder neck is open due to neurological element. In diabetic patient also, they have this problem. The bladder neck, because peripheral neuropathy lead to unable to close the bladder neck very tight. That's one of the underlying cause. Spinal cord injuries. Certain medicine also can give you that. The prostate medicine, it can give you to this. And so the patient gets disappointed by having this. So this is what we call it retrograde ejaculation. An ejaculation, the patient completely unable to ejaculate. And this is usually happen in a spinal cord injury patient, particularly the high spinal cord injury, particularly the sympathetic shin part, and when they're no treatment for this, but in order to achieve this, probably electric ejaculation under anesthesia, through this little probe in the rectum, we put it, we stimulate it, and then the ejaculate will happen. And they use it for vitro fertilization or
vitro fertilization. Excellent. How common, ejaculation problems?
It's not as common as the erectile dysfunction. But it's the premature ejaculation happen particularly at the middle age, where the people related to the stress in the life. Second common cause is the prostatitis. When they get inflamed, it gives this feeling of premature ejaculation. Certain medicine, partner stimulation, adequate timing. Stress itself, it can give you premature ejaculation. So a lot of factors. So again, detailed history is very critical. And what's happening commonly, I see in my clinic, when the patient comes or they present, the first thing they do for looking at their eyes, they look at the door is closed or not.
Sure.
So just right away, I open the door for them and open question about, do you have a problem with sexual relation? Then they go relax. So it's very important to go detail and zoom in more to know where exactly the problem, in order to find out the potential underlying cause so we can treat it.
Excellent. Now, Dr. Maher, we will move to the second, part about diagnosis.
Yeah, well, start with the blood, as I mentioned. The blood, we mentioned that we need to, if there is a concern about testosterone level, you need to check it. LH hormone, is it producing or not? If there is any concern about endocrine disease, like hypothyroid, or the patient having pituitary adenoma with the symptom or potential, check for prolactin as well, because it might be very high.
How prolactin?
Prolactin, it inhibits secretion. It's secreted from posterior pituitary.
Yeah.
So this will inhibit secretion of LH secretion from the testicle, which is responsible for all the desire and the rigidity and the erection ability. So if this is interrupted the cycle, the patient won't be able. Hypothyroid also interfere with this cycle, so the patient won't be able to achieve erection. So make sure you pay attention to this during your blood work.
Hormonal profile, extended hormonal profile.
Yeah.
Okay.
And then you do direct examination of the penis, and by doing Doppler ultrasound. Doppler ultrasound with the stimulation, most of the time we do it. The aim of this, you want to see, are you dealing with arterial or venous problem here?
Excellent.
So we inject the prostaglandin as the stimulant, as we showed in the previous slides. And this will lead to erection, and then you check with the Doppler, you see the flow. So based on the speed, you check the arterial and venous, and you see if there is a leak, you will be able to see it right away.
Excellent. That's very important. What about, prevention? What are the best preventive, measures, to prevent male sexual dysfunction, like erectile dysfunction mainly? Okay.
Yeah. Well, knowing the underlying cause and try to avoid it. So prevent the potential underlying cause, and be aware of the overweight and try to deal with it, and try not to.
So obesity.
Obesity,
okay.
Number one.
Before obesity, I read about a recent study that central obesity.
Yes.
More, affecting the. Is that true? Okay.
It is indeed. What we call metabolic syndrome. Basically, one of the signs is central obesity. The more fat you have around the waist, that's more risk for having peripheral vascular disease, which lead to erectile dysfunction and cardiovascular disease. So this make you at risk for all these pathologies.
Excellent, great.
So be aware of this. Should be aware also of balanced low-fat diet.
Okay.
Patient or the person should avoid smoking and alcohol drinking. Should be exercising at least 30 minutes per day. And to ensure also, some study shows pelvic exercise. Pelvic exercise will be augmented by having not overweight lifting, because significant weight lifting, not going gradual, will affect the erection in the way it gives a venous leak. So people, they just go very fast, and they said this is one of the potential underlying cause. So make sure you go gradual, and you train also your pelvic muscle. So by training the legs, increase the flow to the pelvic muscle.
What kind of exercise? This one?
One of them is Kegel exercise.
What we call it?
Kegel exercise.
Kegel exercise, yes, we heard about it, yes, that.
And also the lower legs, you need to...
what can you explain what Kegel exercise,
because Kegel exercise, see when the person urinating and try to hold, that's the muscle you need to recognize first. And all what you do, tighten all the pelvic muscle together. So by doing it for 5 count, 1, 2, 3, 4, 5, and then relax for the same period, and go gradually. It will help in improving the dribbling that we commonly see, also post-void dribbling. And second, also tighten the continence ability, so people who are having stress incontinence. And third, also increase the flow and rigidity of erection during the erection phase.
So this is no need for special, machines or etc. It can be done at home, okay? Without
At home, reading newspaper, waiting in the car in the very busy traffic in Riyadh. So
excellent. That's very important. So physical activity, exercise, and what's next? Other lifestyle changes.
There is certain medication, in fact, they can be used as part of the lifestyle in those group who are borderline or at risk. What we call it Cialis, 5 milligram. Recently now, they're prescribing to this particular significant group.
So it's not part of treatment. This is preventive.
As a preventive, yes. As
a preventive. Okay, preventive, so that's in addition to the healthy lifestyle, like weight loss, balanced diet, exercise, avoid smoking and alcohol.
And this is a 5 milligram. That's what does it do. It increases the flow to the cavernosal tissue, and without significant side effect and more physiological effect. So it's 5 milligram once daily. It's act like aspirin that we currently use for peripheral vascular disease.
Great, excellent. So I read about the adequacy of sleep. If you have adequate sleep,
definitely,
again, it can influence the.
This is by preventing the stress. So adequate sleep, adequate diet will give you a good 6. You cannot, and most of the patients I see in my clinic, they come very stressful life. One of them is working like CIA agent or something. He's so stressful work, a lot of concern, a lot of responsibility. Another group of patients, they live with the family, or they have 12 kids, etc. So there is no way you have. So you need to have environment. Very important to have adequate sleeping and adequate healthy diet. That will give you a good 6.
Excellent. That's really great, Dr. Maher, that in our, local, let's say, literature, okay, that we say there are natural substances that, stimulate. Is it myth or fact? Is it evidence-based or?
In fact, most of these are not evidence-based, but definitely some of them that will prevent the cholesterol level from being high indirectly will affect the flow, like ginger, for example.
Ginger,
Zafran, obviously, and also there's what we call it antioxidant, like blueberry. Yes, this work as well. Avocado as well. Increasing the HDL rather than LDL, the bad. So pomegranate as well as an antioxidant.
And leafy vegetables, some leafy vegetables like
yeah, that also as well. So knowing this, it's good, healthy, but it's not strongly supported. Okay. It's working for this particularly.
Like adjuvant, or
it's augmenting.
Augmenting. Okay.
But it's not a treatment. But definitely there is a lot of modality of treatment for erectile dysfunction.
Excellent. Before we go for treatment, which is our last, let's say part, we'll be stopping for a break. We'll watch a report about male sexual dysfunction. To watch more details about this report, stay with us, don't go away.
Men, what is the one condition that will affect nearly 50% of us over 40? Sexual dysfunction. On average, nearly 30 million men will suffer from it. But because it is a condition that does not discriminate, men can be affected at any stage of life. In fact, studies have shown that of men who seek treatment for sexual dysfunction, 1 out of 4 are younger than 40 years of age. Many people mistakenly believe that sexual dysfunction in men occurs because of relationship issues or the aging process. But here is a basic definition. Sexual dysfunction is a difficulty during any stage of the sexual encounter, which includes desire, arousal, orgasm, and resolution that prevents the individual or couple from enjoying sexual activity. Erectile dysfunction is one type of sexual dysfunction. It can have many causes. Most are physical, some are psychological. Often, a combination of medical conditions is involved. These may include diabetes, stroke, heart disease, high cholesterol, and high blood pressure. Lifestyle factors such as smoking, drinking too much alcohol, side effects from prescription medications, or stress can also be a factor. In any case, it is simply not a natural consequence of aging, nor should you learn to live with it or be embarrassed to talk to your physician about it. The main difference between people who live with sexual dysfunction and those who recover from it is a simple choice to seek treatment. But it doesn't have to be that way. A simple exam is a key component to understand how sexual dysfunction impacts you and your partner. Just as there are many causes, there are also several different methods of treatment, such as medications, hormonal therapy, psychological therapy, and mechanical aids such as penile implants. The Northwestern Medicine Department of Urology offers comprehensive care for men who have been diagnosed with sexual dysfunction. Our team of urologic experts will work with you to find the best treatment to help you achieve a healthy sex life with your partner. If you're experiencing these symptoms, living with it is not your only option. Contact your physician to discuss ways to reduce your risk and treatment options for sexual dysfunction today.
Once again, welcome back to Elixir of Life. It's my great pleasure to welcome again my distinguished guest, Dr. Maher AlMoazen, and our topic talking about male sexual dysfunction. We paused on the treatment modalities, I think, which is the most important. All dear viewers waiting for this important.
Exactly.
What are the treatment modalities for male sexual dysfunction?
Also, men, particularly on the commonest one, which is erectile dysfunction, and the most important part, from which most of the time we get it from the detailed history and physical, is the psychosexual element. And I would like to highlight also availability or having a specialized, focused psychologist on the sexual disorder is very limited in Saudi.
Subspecialized.
Subspecialized, yeah. But I think this is very important, and they should have their own clinic, and they should be involved in the treatment as a multidisciplinary pattern.
Team, yes.
The psychosexual element is very important in the way of education, knowing the detailed potential underlying cause from psychological point of view. Behavioral therapy and psychotherapy is very important. Probably anxiety, stress, and treat also these potential underlying cause that overcome the sexual or psychological element.
And depression,
as well, depression, yes, potential it might lead to this. Very important sometimes the other partner need to be involved on this, particularly in the sexual education, particularly new couple. New couple, they're not aware, particularly they are not educated, they go into new sexual, new life, they're not aware what's the sex all about, and they need really to know the details and what the stimulation, the man has to take his time, and they have to know what the anatomy of each other's, what are the physiology they go through, any stress, any stimulation, any word, it might be disappointing to the man, etc. So all these need to be also the pain, and the other partner has to be aware of this. How to overcome the first, the honeymoon phase of the premature ejaculation, the honeymoon cystitis, and all this. Or they need to know all about this, and at least a course or to give a talk about this.
So workshop. So now you recommend for premarital workshop. Okay, it's been done nowadays.
It needs to be focused for a woman. They have their own just before the marriage, and the men as well. So they come to the new life. They are prepared. They are ready. They are aware of this, and to know where to go when they require a consultation.
Excellent. So psychosexual counseling. Okay, that's number one. Okay.
The second part is the oral medication. Oral medication, currently the most available one is the 5-phosphodiesterase inhibitor. That's inhibit nitric oxide from cyclic G. So it will accumulate in the tissue, will move more calcium away from the field and lead to more relaxation. And the commonest one it used in the past is Viagra, what we call it, sildenafil, tadalafil in the form of Cialis, or vardenafil in the form of Levitra. They have different half-life, they have different, but the mechanism of action almost the same. Some of them act on different receptors, that's why more side effect. The physician has to be aware of this. The patient as well need to be aware of this. Very important message I would like to deliver. This medicine does not work by itself. It needs stimulation, either visual, audio, tactile, need stimulation. And it might not work from the first time, or the second does not mean a failure. 3 or 4 times it might, until it shows the difference. So don't get disappointed. This is a message to the patient.
So this is these medications prescription should be prescribed by a physician. Is not over-counter medication like what's happening. Can you just highlight or emphasize this point?
Yeah, unfortunately, the people, most of the patients, by the time they come to use, they already try. They don't know how to use. They just hear it from a friend, and it's over-counter. You just go and buy it. It can be very dangerous, because some patient, particularly the patient recent stroke, MI, myocardial infarction recently, heart disease patient, myocardial infarction, patient with the cardiomyopathy, that the heart is not pumping very well, and the patient on nitrate medicine for coronary heart disease, patient with unstable angina, they should not use this medicine without
nitroglycerin. Okay,
nitroglycerin. They should abandon, especially nitro patch. They should. They're also antihypertensive medication. They should not take it at the same time, because it can cause significant drop in the blood pressure.
It used to be used as antihypertensive medication in the past, and still used for pulmonary hypertension.
Pulmonary hypertension. Thank you. So also hypotensive patient should be aware of this. So the patient at high risk, they should not. They should counsel. Even the physician should not prescribe it to them, should counsel their cardiologist or primary treating physician before considering this medicine.
Excellent.
There are certain also liver diseases, the metabolism of this, certain medicine will interact and it augment the effect of this, like ketoconazole, etc. So this will inhibit the certain enzyme in the liver, so it will not break it, it will go high in the level in the blood. So awareness of this is very important. It's not easy medicine. It can
so it's not risk-free. It can be
life-threatening.
Life-threatening, and that's why we hear about sudden death after using, sildenafil or Viagra. So that's the point.
Taking high dose, not aware of the side effect, and this will bring us also lead us to the side effect of this. The Viagra particularly has more side effects. They are all sharing the commonest side effect: the congestion of the nose, flushing of the face. They feel throbbing headache sometimes. Blurred vision, because Viagra work on certain receptor on the eye that the others they don't. So they might have blue, greenish color of circles on their eyes. That's because of the medicine. The also interaction, as I mentioned, with the other medicine, they might cause also dyspepsia or heartburn when they take this medicine. The Cialis, it causes different side effect with lower back pain. So whoever taking this medicine, yes, it lasts longer, but they might feel it's a muscular, it's myalgia, and it goes away as the time goes. Vardenafil is the same. There's coming also as sublingual medicine or patches now recently. But again, this is not commonly used, and the dose distribution and absorption is not as it's taking it oral, so the first pass in the liver.
Excellent.
This is very important, again, need to be aware of. This, again, another medicine that can be used, apomorphine. This is acting centrally in certain center on the hypothalamus, and this will coordinate the sexual stimulation and augmented it. So the patient, if they feel arousability, it will be stimulated higher. But it also has its own side effect of dizziness, headache when they take this
is
medicine.
it really available in the kingdom, apomorphine, or this is?
Until recently, in fact, it can be taken sublingual.
Sublingual.
Yes. The other medicine, it can be used, that's intraurethral medicine.
So before we go, to talk about injectable medication, the oral medication, to emphasize the point that you mentioned, we should be, aware about the indication, side effect interaction, and it's very important. Drug interactions.
Yes.
Drug interaction and contraindication. Okay, yes. That this is very important because this is the most commonly used treatment modality. Before we talk about the injectable medication,
and it needs stimulation. And using it once or twice is not a failure. 3 or 4 times until you judge, and you have to titrate the dose by your physician. Need to titrate it up.
Excellent.
Yes, it's very important.
Great.
Moving again to the intraurethral.
Excellent.
We can, as you show, intraurethral probably is not in this, but it's a special applicators. We apply it, ask the patient to urinate before, at the tip of the penis, at the meatus, at the opening of the urethra, and we press on it, will release a pellet. This pellet will go and get absorbed inside. This prostaglandin is the direct stimulation to cyclic AMP, which act like cyclic GMP, decrease the calcium inside the cell, lead to dilatation. The potential side effect is the pain. It might cause mild discomfort, and if it's used with the high dose, it might cause uterine contraction in the partner, and also it can give priapism. Priapism is persistent, painful erection due to this side effect. So if it lasts more than 4 hours, the patient has to go and counsel the emergency because it might be irreversible.
Excellent. So this is done by the physician, healthcare professional, or by the patient?
The patient, but giving the instruction. And you show them initially in the clinic how they
education,
use it. The second one, we call it intracorporeal injection. The commonest one, in the previous slide, you go, please. The intracorporeal injection, and the down there. This is, we call it 3PP, prostaglandin, papaverine, and phentolamine. Different medicine act on different level of receptors and different mechanism, but they're all augmenting each other, synergistic effect they have. And this will lead to erection. Use a very small needle injected in the lateral aspect of the penis, and it gives the erection. It should be, the first injection should be done by the physician. It shows how to do it. And the patient should have adequate dexterity and adequate mental capacity to understand the medicine and the potential side effect and what to do, where to go when side effect happen. The common side effect is local bleeding, discomfort, and priapism. It can happen with this. This is, we usually prescribe it for elderly when they have established sexual life for a long time. Not
a second line, a second
line
after oral medication
of the other oral medication. The other modality is what we call on the left upper side of the screen, on the upper side of the screen, is a vacuum device. It's made of 3 pieces: the pump, the chamber where they put the penis, will suck the air and evacuate it, so the blood will go in passive way to the corporal tissue, and constrictive device. Once the erection happens, you leave it behind. It is discomforting and painful. They came with another modality of, other than this, it's less pain, and the aim of this is to retain the blood inside the penis, so in order to achieve erection. You should not keep the constrictive device more than half an hour. And the side effect of this device, it leads to coldness and discomfort and pain of the penis, and bruising as well. There is another device where they use as stretching the penis without any stimulation. Is just more mechanical. It has 2 rings.
For enlargement, is it the one that the same for enlargement?
The enlargement is called andro penis. The enlargement device is a stretching device. As you know, this is sponge-like tissue. You mentioned it earlier. And we've seen it all in the African woman, as they're using that as a part of their beautiness. They apply a ring on the neck, and they keep increasing them. That will stretch the neck. And imagine you have bone, you have vascular tissue, you have muscle, you have everything there, and yet it keep lengthening up. So that's exactly what happened in this. You keep stretching it and keep it on the same length for a period of time, will adapt more length. And the more you do it, and give you as well, it increases the length as well as the girth. But it needs time, and you need patience. Most of the patients, they are not patient, and they're pushing up for surgery. Yeah, after this, we have what we call it, we move to the next slide. This is penile procedure. There are 3 part of penile procedure.
This is the last resort.
The last resort. There is another modality I'm going to highlight on it after this, and the penile prosthesis, there are 3 types. There is malleable one. There is no pump in there. It's just made of silicone. We open in the tissue inside the penis scrotal level. We make a small opening. We open the corpora itself. We do dilatation, and we leave this device behind, and we close the skin. It should be used 6 weeks after the first surgery, so the wound will heal completely. The problem with this device is one way. You can't use anything after this but the penile prosthesis. So if it get infected, if it get erosion, you need to replace them with the same device. So you need to be aware, the patient need to be brought to that it does work very well. You don't need erosibility or stimulation, and it's in your hand. Even with ejaculation, it's still the erection there, still the desire, you can finish. It has nothing to do with the desire or your sensation or ejaculation ability.
Excellent.
So it's in the patient hand, the control. But in the other side effect is one way. You can't use anything because you're damaging the corpora itself. And
it cannot be removed.
It can be removed, but and replaced with another one.
Okay.
Yes. So that's why you really need to ensure that blood sugar level very well controlled before you consider. The patient is very well, the whole field is soaked with the antibiotic when implanted. The patient need to be covered with antibiotic. It needs plenty of time to do it before you consider this prosthesis.
Excellent. So this is like last resort and for burnout, advanced stages, elderly patient, not for young patient.
Well,
okay?
Particular group of young patients that when they have vascular disease, particularly the phenogenic, there is the current available surgery, the closure, it does not work very well. And if they fail of all the other modalities, they don't adapt the vacuum device, you consider this for
excellent. Doctor, before we close our interesting interview, what are the take-home messages from your interview? Okay.
The take-home message: sexual disorder is quite common. Is not shame to consult or to ask for a help. It's excellent for your partner relationship, and the lifestyle modification is very important to ensure sustainability of a healthy sexual life, and also awareness of the medicine that you as a patient taking it for sexual treatment. It is not without negative side effect. You should be aware of it. You should be aware of your medical disease. You should take it with consultation of your physician, not just over counter. Thank you.
Thank you, Dr. Maher, AlMoazen consultant urologist, for enlightening us about very important and sensitive topic. It's been a great pleasure.
Thank you.
And would like to see you again in our program.
Thank you very much.
With that, we are coming to the end of our program. Thank you for joining us today. We wish as a team that you have enjoyed our episode and found it useful, motivating and stimulating. Until next time, we wish you a pleasant week ahead. Assalamu alaikum wa rahmatullahi wa barakatuh. Goodbye.